السلام عليكم ورحمة الله وبركاته. I am Dr. Shaimaa Mustafa, Assistant Professor of Cardiovascular Medicine, Banah University. I will discuss with you today mitral valve disease. Anatomy of the mitral valve apparatus. The mitral valve consists of both leaflets, anterolateral and posteromedial, mitral valve, annulus, cordia, and papillary muscle. The most common etiologies of mitral valve disease in general are rheumatic fever, congenital mitral stenosis, rare complication of carcinoid, systemic lupus, rheumatoid arthritis, mucopolysaccharidosis, Whipple disease, and amyloid deposition. Mitral annular calcification may extend to end-of-base leaflets, especially base of the posterior leaflet, and obstructive physiology in case of myxoma, infective endocarditis, or core triatrium. The etiology of mitral valve disease in both male and female is changing over time. We can see from this graph that the ischemic etiology is declining, rheumatic etiology is declining, but the degenerative changes is increasing. We will focus today on mitral valve stenosis. Normal mitral valve area is 5 cm square. Symptoms start if the area less than 2 cm square, and hemodynamic changes start at less than 1.5 cm square. The American Heart Association developed a heart valve disease symptom tracker. This tracker system include most of the symptoms that may develop due to valve disease. If the patient every now and then use this symptoms tracker, we can assess if the patient is getting better or getting worse. This, of course, in association with the clinical signs as pulse, blood pressure, jugular venous pressure, cardiac examination in the form of apical impulse, pulsation, parasternal heave, type of apex speed, and palpable sound and thrill, which can assess the severity of mitral stenosis. The murmur of mitral stenosis is the systolic rumbling sound, which starts after S2 and end at S1. Opening snap indicate pliable leaflets. Longer murmur indicate severe mitral stenosis. Other murmurs in case of mitral stenosis are systolic ejection systolic murmur in pulmonary area due to pulmonary hypertension, and apical systolic murmur in case of parasternal systolic murmur in case of severe tricuspid regurg. Echocardiography is the imaging modality of choice for assessment of patient with mitral valve disease. By transthoracic and transesophageal echo, we can assess the severity of mitral valve stenosis. We can assess the etiology of mitral valve stenosis, and the rheumatic etiology is the most common etiology in case of stenosis, which can be assessed by, as we can see in this video, by ankylosed posterior leaflet, hockey stick sign of the anterior leaflet, enlarged left atrium, systolic right left ventricular systolic function, and severity of tricuspid regurg, pulmonary hypertension, associated mitral regurg, and aortic valve disease in association. We can assess mitral valve area from the apical four-chamber view, either by a transthoracic or transesophageal by pressure half-time method, and the parasternal short-axis view by planimetry method, which is the recommended method by the European Society of Cardiology and the American Heart Association. But 3D echo offer a more accurate assessment of mitral valve area. American Heart Association guidelines in 2020 considered mitral valve area less than 1.5 cm square as severe mitral stenosis, while if the area is more than 1.5, a progressive mitral stenosis. For appropriate choice of the management strategy of patient with mitral stenosis, area is not the only factor. We should consider the patient symptoms, pliability of the mitral valve, presence of a mitral regurg, rhythm of the patient, as in case of new onset of AF, pulmonary artery systolic pressure. Management of patient with mitral stenosis indicate either by balloon mitral valvoplasty or mitral valve replacement. Thank you.